Um, Good morning, everyone. Myself, Dr. Niharika, I am an assistant professor in the Department of Ophthalmology. Today, I am taking a topic of intraocular tumors. So, what are intraocular tumors? So, intraocular tumors could be pigmented tumors or non-pigmented tumors. So, what are pigmented tumors? This is such like choroidal melanomas is the most common intraocular tumors in adults. Clinical examination is the method of choice to diagnose choroidal melanoma and to differentiate a choroidal nevus from a small choroidal melanoma. Other common intraocular pigmented tumors includes optic nerve head melanocytoma, retinal pigment epithelial adenoma, and combined hematoma of retina and retinal pigment epithelium. So these are some of the examples of pigmented tumors. But in these, the most common is choroidal melanoma, which is the most common intraocular tumors in adults. The other one is the non-pigmented tumors. So the choroidal non-pigmented masses includes amelanotic melanoma, uveal granuloma, lymphoma, osteoma, and choroidal metastasis. Choroidal hemangioma has a characteristic orange color and is usually associated with the subretinal fluid transudations. So the choroidal hemangioma has a characteristic orange color. So see in the first picture, this is the characteristic orange color and is usually associated with the subretinal fluid transudation. So in it, you can see in the first picture, you can see there is a accumulation of the fluid underneath the retina, that is in the subretinal space. The retinal non-pigmented masses includes retinoblastoma, astrocytoma, and the toxocara granuloma. So these are the example of non-pigmented retinal masses, which includes retinoblastoma, astrocytoma, and toxocara granuloma. So these are some of the tumors which I'm not taking in the detail, but you must know about the 1-2 lines about it. That is like the rhabdomyosarcoma, rhabdomyosarcoma, which is the most common primary orbital malignancy in children. So rhabdomyosarcoma is the most common malignancy in children. Capillary hemangioma is the most common tumor of organs and periorbital areas in the children. So these is the most common tumors of the orbital and the periorbital areas in the children. That is a capillary hemangioma. Third is the cavernous hemangioma. It is the most common benign orbital tumors in adult. So this is the cavernous hemangioma is a benign orbital tumor in adults. Fourth is the neuroblastoma, which is the most common of orbital metastasis in children. So these are some of the tumors which I'm not taking in the detail, but you have to learn it because it comes in your MCQs. So rhabdomyosarcoma is the most common primary orbital malignancy in children. And capillary hemangioma is the most common tumor of the orbital and the periorbital areas in the children. Cavernous hemangioma, which is the most common benign orbital tumors in adults. And neuroblastoma is the most common cause of orbital metastasis in the children. Okay, so we'll deal with the melanoma of choroid, which is what is a melanoma of choroid? It's the most common primary intraocular tumors in adult, and it accounts for the 85% of the uveal melanoma. So choroidal melanoma is the most common intraocular tumors in adult, and it accounts for the 85% of the uveal melanomas. Age of presentation is between the 40 to 70 years. Race, rare in blacks and more common in whites. Laterality is usually unilateral and arises from the outer layer of the choroid. As the name suggests, it's a melanoma. Melanoma is the pigmented tumor, which occurs in the choroid. So it is the most common primary intraocular tumors in adults. It accounts for the 85%. It's unilateral and the age of presentation is 40 to 70 years. See, in this picture, you can see this is the pigmentation on the choroidal layer and this is a choroidal melanoma. The sequence of events. It arises from the outer layer of choroid. Okay, there are 3 layers of the eyeball. That is the retina, choroid and the sclera. So it arises from the outer layer of choroid. Then it first forms a lens shaped mass rising the retina over it. Okay, that is the raising the retina over it. So it is forms a, it arises from the outer layer of the choroid, then it raises the retina. So in the it is in the shape of concave. So first forms a lens shaped mass raising the retina over it. As it grows, it stretches the elastic membrane of the brush, which finally ruptures. So there is a layer in the retina which is known as the brush membrane. So when it grows from the retina, it stretches the brush membrane and finally it ruptures. Tumor then proliferates through the opening and the retinal pigment epithelium to form a globular mass in the subretinal space. So the sequence you can imagine, that is, it is arise from the choroid. Then the choroid, the upper layer of the choroid is the retina. So when the mass from the choroid arises or it forms, when it increases in its size, then it forms, and then it will layer, then the upper layer of the choroid is the retina. So first it will raise the retina over it. Then as the mass increases, the elastic membrane of the brush will be ruptured and the tumor then proliferates through this the opening and it comes into the retinal epithelium, pigmented epithelium, and there it forms a globular mass in the subretinal space. Okay, to get the sequence, first it arises from the choroid, and then as the mass increases in size, then it will rupture the retina. In the retina, it will first rupture the brush membrane, and then after the brush membrane, it comes in the layer of the other layer of the retina, that is the retinal pigment epithelium, and there it forms a globular mass, which now it comes in the subretinal space. The neurosensory retina remains in contact with the tumor at the summit, but is detached from the choroid at the site. So the neurosensory retina, which is the main the sensory retina of which is the main neurosensory layer of the retina, which comes after the retinal pigment epithelium. So it remains in touch with the tumor. As the tumor increases in size, it is attached with the neurosensory retina, but at the summit, it is detached. The intervening space is being filled with the exudative fluid leading to the retinal detachment, starting from the dependent part. So after as the space, now the intervening space in between the mass and the layer of the retina, there is filled with the exudative fluid, which will lead to the retinal detachment. Later, the tumor fills the globe. Before perforating the sclera, which occurs along the perivascular space of the vortex vein or the ciliary vessels. Now the tumor comes in the subretinal space. Now later the tumor fills the globe before perforating the sclera. Now as the mass will increases, as the mass increases further, as the size of the mass will increase, then it will fill the tumor fills the globe before perforating the sclera, which occurs along the perivascular space of the vortex vein or the ciliary vessel. Okay, so these are the sequence of the events. So it starts from the choroid, then it forms a lens-shaped form, which forms a lens-shaped mass which covers the which is overlined with the retinal layer. Then as it grows, it stretches the elastic membrane of the brush and finally it ruptures. Then it comes into the subretinal space. Okay. Now after that, the neurosensory retina, which comes after the retinal pigment epithelial layer, it remains in contact with the mass and otherwise it remains at the attached in contact with the tumor at the summit, but is detached from the choroid at the site. The intervening space is being filled with the subretinal fluid, and thus the retinal detachment occurs. Later, the tumor fills the globe before perforating the sclera. Okay. So now the gross pathology. So gross pathology, it is of two types, that is circumscribed and the diffused. Okay, circumscribed means that it comes in the pendulated form. That is a pedunculated form. It is most common form, appears as the flat slate gray area which become raised and pigmented with growth and eventually ruptures through the Bruch membrane. That is also known as the collar stud tumor. This is the characteristic feature of the choroidal melanoma. You should know this is very important as it comes in your MCQs. That is a collar stud tumor. So it is the characteristic feature of the choroidal melanoma. So gross pathology, it is of two types, that is the circumscribed or the pedunculated, and the diffuse, that is the flat tumor. So circumscribed getting pedunculated by its name, it is most common form, and it appears as a flat slate, that is gray area, which become raised. First it becomes a pigmented, then it raised as the size increases, it raised and pigmented with growth and become more pigmented after the growth and eventually ruptures the Bruch membrane. That is the collar stud of tumor. Other one is the diffuse or the flat tumor, which is very rare. So it is a collar stud tumor. This is gross pathology. The most common is the collar stud tumor. Histopathological types of melanoma. So it can be of spindle cell type, mixed cell types, epithelioid cell type, and the necrotic. So the most common in this, in the histopathological of the melanoma, the most common is the spindle cell type or the mixed cell type. It is of 45%. Other is the epithelioid cell type and the necrotic. Now the stages of the clinical progression of the melanoma. First, there are the 4 stages of the choroidal melanoma. That is the progression of the melanoma. So the first is the quiescent stage. Second is the glaucomatous stage. Third is the stage of the extraocular extension, and the fourth is the stage of distant metastasis. So first is the quiescent stage. Okay. So in the quiescent stage, there will occur only in the quiescent stage. In this, will be no any signs and symptoms, just the blurring of the vision will be there. In the second, in the glaucomatous stage, where in this, because of their increase in the size, there will be because of the pressure inside the eyeball due to the increase in the size of the mass, there occur the glaucomatous stage. That is, there will be the increase in the intraocular pressure. And third is the stage of the extraocular extension. So in this, there will be the stage of extraocular extension. Extraocular extension means it can be occur in the sclera or in the other part of the eye. And the fourth is the stage of distant metastasis, that is, it involves the other part of the lungs, other part of the body, organs of the body. Now comes the differential diagnosis. As it is pigmented, so the differential diagnosis comes in the nevius, which is also the pigmented part or the pigmented area of the eyeball, which it's not any differential which is not increase in the, it may increase in the side, but it cannot be the malignancies. The second is the melanocytoma. Third is the hyperplasia of the pigment epithelium. Fourth is a retinal detachment. There also occur the retinal detachment of the choroidal melanoma, choroidal hemangiomas, which includes the vessels also, choroidal vessels, metastasis, or the acute glaucoma. Okay, so these are the differential diagnosis of the choroidal melanoma. That is nevius. This is the first most common, which is the nevius. Second is the melanocytoma. Third is the hyperplasia of the pigmented epithelium, retinal detachment, or choroidal hemangiomas, or the metastasis, and the acute glaucoma. So these are the differential diagnosis of the choroidal melanoma, which can mimics like the choroidal melanoma. So now if we are detecting that this is a choroidal melanoma, we have to went for the further investigations. So this can be the indirect ophthalmoscopy, by which we can see the fundus, transillumination test to differentiate between the simple retinal detachment and the choroidal detachment, USG A scan or the USG B scan, radioactive tracer, that is the principle is of this is the neoplastic tissues has an increased rate of phosphate 32 intake. In our MRI, there is a hyperintense on the T1 weighted and hypotense hypointense on the T2 weighted images. So these are the few of the investigations. For this, we have to do, like, the first is the indirect ophthalmoscopy to see the fundus, or second is the transillumination test. In this, we get to differentiate between the simple retinal detachment and the choroidal detachment. So in the transillumination test will be the positive in the retinal detachment, as there is only the subretinal fluid in the retinal layer, and in the choroidal detachment it will be the negative, as there is a mass inside the retinal layer. In the UAC A scan and the B scan, we can see in the UAC B scan, we can see that characteristic feature of the choroidal melanoma, that is the appearance of the collar stud appearance. There is a, we can see there is a globular mass in the choroidal layer. We can detect in the UAC B scan. The treatment of the malignant melanoma of the choroid is first will be the conservative, but it's only in the quiescent stage, or it can be enucleation if if enucleation only in that condition if it involves the intraocular structure, or only the it will involve only the eye. Okay, the exenteration is a very exenteration is a very in exenteration we'll we'll remove the eye along with the orbital content also, like the orbital covering also, like we have to remove in exenteration, we have to remove all the walls, we have to remove the eyelids. So this is very so in this exenteration, exenteration can be done only in the conditions like if there is a distant metastasis. Okay, and the palliative, third was the palliative treatment using the chemotherapy and the immunotherapy. Only this is palliative using chemotherapy and the immunotherapy. This should be start after the enucleation or the exenteration. Okay, so the treatment of malignant melanoma of choroid is the conservative or the enucleation. If the tumor is in the intraocular cavity, then we have to do enucleation. If there is a distant metastasis, then you have to take extraocular extension. Then we have to do exenteration. And after that, we have to do the palliative using chemotherapy and the immunotherapy. So these are some of the these are the treatment line of the malignant melanoma. So this is the management of the local resection of the unifocal intraocular tumors with preservation of an eye. So in this, if there is a localized or if there is a small to medium sized tumors of the iris, ciliary body, or the peripheral choroid, then we can go with the local resection without removing the eye. Only the tumors we have to remove. That is a local resection of unifocal intraocular tumors. With preservation of the eye is advocated for the small to medium sized tumors of the iris, ciliary body, and the peripheral choroid. So these are some of the conservative and the surgical treatment. So brachytherapy, usually the treatment of the choice in tumor of size less than 10 mm in elevation and by the 20 mm in the basal diameter. So if the tumor size is if it's less than 10 mm in the elevation, so if the tumor is of small to medium size, that is of less than 10 mm in the elevation and 20 mm in the basal diameter, then we can go with the brachytherapy. That is a conservative treatment. In this, we don't have to remove the eyeball. Okay, the second is the external beam radiotherapy. If the condition is unsuitable for the brachytherapy, then we have to go with the external beam radiotherapy. Third is the transpupillary thermotherapy with the diode laser. and transscleral local resection in 10 to 16 mm size of the tumor. If there is more than 10 mm of size of the tumor, then we have to go with the transscleral local resection, that is a focal resection. So these are the conservative treatment. So in this we have to do like the break. First is the brachytherapy. If it's a treatment of the choice, if the tumor size is of 10 mm in elevation and 20 mm in the basal diameter. And second is the external beam radiotherapy if it is unsuitable for the brachytherapy. Third is the transpupillary thermotherapy with the diode laser, or fourth is the transscleral local resection in the case of if the size of tumor is between 10 to 16 mm. So these are some of the conservative and the surgical treatment of the choroidal melanoma. So in this, the latest technique of for the treatment of the choroidal melanoma is the stereotactic radiosurgery. It is indicated in the large tumors, done with the help of gamma knife, involves single session delivery of ionizing radiations to a stereotactically localized volume of tissues. So in this, that is in the stereotactic radiosurgery, it is a radiosurgery. So it is indicated in the large tumors, but if the size of the tumor is above 16 mm, and it is done with the help of gamma knife, involves single session delivery of ionizing radiations to a stereotactically localized volume of tissues. So in this condition, so in this technique, there is a direct that is involved. It is only involved the session, only a single session is involved, and in this the radiation is given towards that is which are active tissues, active malignant tissues of the tumor. So it directly radiates to the tissues which are actively proliferating. Okay, so it delivers delivery of the ionizing radiations to a stereotactically localized volume of tissues. Okay, so this is the stereotactic radiosurgery. It directly radiates to the proliferating cells of the tissue, also proliferating cells of the tumors. So this is the latest technique, that is the stereotactic radiosurgery, and it is indicated in the large tumors. Okay, so these are the choroidal melanomas. So choroidal melanoma is the most common intraocular tumors in the adult. It is the pigmented tumors, and the age of presentations is between the 40 to 70 years of age. Okay, so this is a pigmented tumor. It comes in the 4 stages, like the quiescent stage. Second stage will come at that is the glaucomata stage. Third, it involves the extraocular involvement, and the fourth is the distance metastasis. So these are the 4 stages of the choroidal melanoma. And the first is the characteristic feature of the choroidal melanoma is the collar stud appearance, which we'll see in the USG-B scan. That is the lens-shaped globular mass. That is lens-shaped globular mass which arises from the choroid, which ruptures the retina and the Bruch membrane, and it ruptures the retina and the Bruch membrane, and it is when the tumor is overlined with the retinal pigment epithelium. Okay, so I add as the intervening space. Beside there is an intervening space of the tumor which is filled with the subretinal fluid, which leads to the retinal detachment. Okay, so these are some of the salient features of the choroidal melanoma which we have to be learned. Okay. Now we'll deal with the retinoblastoma. So this is the retinoblastoma which occurs, that is here you can see the small child, and here is the retinoblastoma picture in the retina. Okay. So it is the most common primary malignant intraocular tumor of children. It is second to the uveal melanoma in the general population. Okay, so it is the most common tumor. There is a primary malignant tumor, intraocular tumors of the children. Okay, this is the second to the uveal melanoma. That is the first is the rhabdomyosarcoma. The second one is the retinoblastoma, and it is seen in 1:1400 to 20,000 live births. Age usually becomes apparent by the 3 years. Okay, so it is the most common primary malignant intraocular tumor of children, and is second to the uveal melanomas in the general populations, and the age usually become apparent by the 3 years. Pathogenesis, it is a genetic predisposition. In it, there is a genetic predisposition, malignant transformations of the primitive retinal cells. So in the retina, there are some of the, because of the genetic predisposition, there are some of the primitive retinal cells, which leads it to the malignant transformation. Due to defect or the loss of the retinoblastoma gene, that is the 13q14 suppressor gene. These are the suppressor genes. So due to the defect or the loss of the retinoblastoma gene, that is the suppressor gene, it occurs because of the defect or the loss of the retinoblastoma gene. In it, there occurs the somatic or the germinal mutations. There is one hypothesis known as the nuts and two hit hypothesis. So because of these are some of the pathogenesis like the genetic predisposition, and there is a malignant transformation of the primitive retinal cells. Okay, then it occurs because due to the defect or the loss of the retinoblastoma gene, that is the 13q14 suppressor gene, and in it there occurs the somatic or the germinal mutations, and also occurs, there is one hypothesis is given which is known as the nuts and two hit hypothesis. So in this, these are some of the signs you can see in a case of the retinoblastoma. See, this is the proptosis. In this, you can see there is a bulging of an eye. Okay, there is a bulging of an right eye. So this is known as bulging of an eye is known as the proptosis. Okay. Second, retinoblastoma with the vitreous seeding. Here you can see this is the fundus picture of an retinoblastoma. In this, you can see this is the calcification mask in the retina. This is the white part is the calcification part, which is known as the retinoblastoma with the vitreous seeding. You can see that there's a small dot in the vitreous part. So this is the vitreous seeding. So this is the picture of retinoblastoma with the vitreous seeding. Or this is the retinoblastoma. You can see this is an optic nerve, and this is the vessel. This is the retina, and the mass is coming towards the lens. Okay, so it is growing in toward the lens. So the mass is growing toward the lens. Okay, this is the dissected part of an eye, that is after the seen in the pathology part. You can see the dissected, this is the cut part of an eyeball. You can see this is the whitish calcification part, which is known as this is the retinoblastoma, and it involves the optic end. You can see all this is the optic now. So this is the lens, this is the anterior part of an eyeball, this is the vitreous cavity or the retina. You can see this is the calcification. So this is the retinoma, which it is also involving the optic nerve. Okay. So here you can see that the bulging of an optic nerve. So this is involved, the optic nerve involvement is also there. So what are the most common types? What are the most common characteristic features? What are the findings you can see in the retinoblastomas? First is the intraretinal. So intraretinal means there is a retinoblastoma is confined only inside the retina. So it's not, it is in the intraretinal space only, or in the subretinal space. Okay. Then the endophytic. Endophytic means that is a growth of the retinoblastoma is toward the eyeball. Okay, it starts from the it starts from the any layer of the any layer, that is a retinal layer of the eyeball, and the growth will occur inside the or toward the lens. This is known as endophytic. Exophytic means if that is the growth of the retinoblastoma is outside the eyeball, so it involves a sclera or optic nerve. Okay, so this is the exophytic type. So intraretinal means there is a growth which is confined only inside the eyeball. Endophytic, but when the growth is toward the lens. Exophytic means its growth is toward the sclera, outside. In histology, you can see these are the characteristic histological finding, that is the flexner, Wintersteiner rosette, Homer Wright rosette, and fluoride. So these three are the characteristic histological feature which you have to learn, because it comes in your MCQs. That is what are the three characteristic feature, histological feature, that is the flexner, Wintersteiner rosette, Homer Wright rosette, and the fluoride. So see, as I said, that is endophytic, that is the growth is toward the lens. Here you can see this is the retina and this is the retinoblastoma growth, which is growing upward, that is it is going toward the lens. Okay. Exophytic tumor in which there is this is the retina. Here you can see the growth which is coming to outside, which is the growth is toward the sclera. So you can't see any bulging over the retina. Okay. So these are some of the findings you can see, that is the intraretinal, endophytic, exophytic, histology, and flexor, Wintersteiner rosette. In histology, you can see the three characteristic features, that is the flexner, Wintersteiner rosette, Homer Wright rosette, and the fluoride. So you have to learn these three important. So the findings in this, the finding will be it involves the proptosis, optic nerve involvement. So if okay, fine. Now the investigations. Now to detect the retinoblastoma, following investigations you have to be done. That is the CBC, that is the complete blood count, serum, LDH, USG, X-ray chest or skull, CT scan, MRI, or the bone marrow biopsy. So investigative tools are valuable to differentiate some tumors from the other tumors. Like the other tumors, like that is the simulating the intraocular mass. They are basic for precise measurement of the tumor dimensions for accurate follow-up. Okay, so investigation to some other investigation which will we have to differentiate some tumors from the other tumors, like the simulating the intraocular masses, and they are basic for the precise measurement of tumor dimension for the accurate follow-up, or for the and also for the accurate treatment. The most commonly used investigative technique includes intraocular transillumination, ultrasonography, fundus photography, and angiography, and the Doppler ultrasonography. Okay, so these are some of the most common investigative techniques in which are the intraocular transillumination, that is the red-free filters, ultrasonography, that is a USC, fundus photography, and the angiography, and the Doppler ultrasonography. Systemic associations of the retinoblastoma. The other tumors like which simulates the retinoblastoma is the pineal. This is a secondary tumors which can be associated with the retinoblastoma. So this is the pinealoblastoma, which is also known as the trilateral retinoblastoma. Okay, so trilateral retinoblastoma, that is if the retinoblastoma is associated with the pinealoblastoma, then it is also known as the trilateral retinoblastoma. Osteogenic sarcoma, soft tissue sarcoma, and 13q deletion syndrome. So these are the other tumors which simulate or which can be associated with the retinoblastoma. There is the pinealoblastoma, osteogenic sarcoma, soft tissue sarcoma, and 13q14 deletion syndrome. So you have to learn this, the pinealoblastoma. This will come in your MCQ. That is a pineal. What is associated with the which tumor is associated with the retinoblastoma? So it comes a pinealoblastoma. That is a trilateral retinoblastoma. Osteogenic sarcoma, soft tissue sarcoma, and the 13q14 deletion syndrome. So these are the classification which is very important in the case of the retinoblastoma, which is known as a Rees-Ellsworth classification. And the classification is according like the group 1, which have very favorable prognosis. It also group A includes the group 1A, 1B, 2A, and 2B. So in the 1A there is a single tumor, In 1A, there comes a single tumor, which is of the less than 4 disc diameter, which is in the size of less than 4 disc diameter, and it is the at or the posterior to the equator. Okay, the 1B, it includes a multiple tumor with of size less than 4 disc diameter, okay, at or the post to the equator. Okay, so 1B is that is 1B is a multiple tumors. 1B, which includes the multiple tumors of size less than 4 disc diameter. It is at the which is present at or the posterior to the equator. Okay, the second is the 2A, which includes a single tumor of 4 to 10 disc diameter, which is present at or the posterior to the equator. And 2B is the multiple tumor, which is of 4 to 10 disc diameter. Okay, so and the further is a 3A, 3B, which includes any tumor anterior to the equator. It comes in 3A. 3B is the single tumor of 10 disc diameter posterior to the equator. That is 3 comes in the 3B, where there is the single tumor, but the size is of 10 disc diameter, and it is posterior to the equator. So it will that will increase in the size. So after the 1A, 1B, 2A, 2B, there will be the tumor of size 4 disc diameter. And in 3B, there is a single tumor of size 10 disc diameter, which is posterior to the equator. 4A, which is of multiple tumor, there is a multiple tumor of about 10 disc diameter or less than 10 disc diameter, or more than 10 disc diameter. Okay, so that is in the 4A, there will be the multiple tumors or of a size 10 disc diameter or more than 10 disc diameter. 4B, any tumors that is anterior to the ora serrata. That comes in the classification of 4B. That is any tumor anterior to the ora serrata. In 5A, there is a tumor with a retinoblastoma or a tumor which involving the more than half of the retina. So it comes in the 5A. And in 5B, there is a vitreous seeding. So these Ellsworth classification, which includes the grading of from 1A to the 5A. So in 1A, there is a single tumor which of less than 4 disc diameter in size, which is present at or the posterior to the equator. In the 1B, there will be the multiple tumors of less than 4 disc diameter, which is present at or the posterior to the equator. And now the 2A. That is a single tumor of 4 to 10 disc diameter at or the posterior to the equator. That is and then the 2B, that will be the multiple tumors of 4 to 10 disc diameter. And in 3A, there is any tumor that is anterior to the equator. Okay, so in any tumor, 3A will be the any tumor or anterior to the equator. 3B, that is a single tumor of 10 disc diameter posterior to the equator. In 4A, there is a multiple tumors, which is of 10 disc diameter or more than 10 disc diameter. In 4B, any tumor which is anterior to the ora serrata, and 5A tumor which is involving more than half of the retina, and 5B is the vitreous seeding. These are the Ellsworth classification. According to that, we can grade the retinoblastoma, and we can plan a treatment according to it. So this is important. You have to learn it. That is the Ellsworth classification of the retinoblastoma. So the treatment of the retinoblastoma, it depends according to the treatment line will be according to the grading, that is the classification of the retinoblastoma, grade of the retinoblastoma. So in first, what treatment comes under the retinoblastoma is the first is the chemotherapy. Okay, so in chemotherapy will include that in chemotherapy, the drugs are used is the vincristine, etoposide, and the carboplatin. Okay. So what are the drugs? That is the vincristine, etoposides, and the carboplatin. That is a VEC. So these are the drugs which is used in the which is used in the chemotherapy. Okay, that is a 3 to 4 weekly cycle. We have to the chemotherapy runs in the 3 to 4 weekly cycles. Okay, so drugs are the vincristine, etoposides, and the carboplatin. Okay. So chemotherapy indications are chemoreductions, especially if the retinoblastoma is a bilateral, or so we have to, that is the by chemotherapy we have to reduce the size of the tumor. That is a chemoreductions. That is especially if there is a bilateral tumor. Extraocular involvement. That is, extraocular involvement means it involves the optic nerve. There is an extension of the retinoblastoma that is the optic nerve. Orbital recurrence after enucleation. So the indication orbital recurrence after enucleation. So after enucleation, that is after removing the eyeball, some of the vitreous, some of the that is a part of the retinoblastoma will remain inside the orbital cavity. So there occur the recurrence of the retinoblastoma. That is the orbital recurrence after enucleation. Metastasis or the intracranial involvement. So these are the conditions where we can give the chemotherapy. That is for the chemoreductions, if there, especially if the retinoblastoma is bilateral. Extraocular involvement, that is, it involves the optic nerve. Orbital recurrence after enucleation. Metastasis or the intracranial involvement. Okay. So these are some of the indications where we can use the chemotherapy. Surgical management, that is the enucleation. Enucleation means we have to remove the eyeball along with the, in enucleation will remove the eyeball, complete eyeball along with the optic nerve. So enucleation, good results if the tumor is only intraocular. Must attempted to get a long stump of optic nerve, that is 10 to 15 mm. So in the enucleation, we have to remove the eyeball along with the optic nerve. So in the retinoblastoma, it is a must to cut the optic nerve also. That is a long stump of optic nerve. That is about 10 to 15 mm of the optic nerve must be cut at the time of the enucleation. At the time of removing the eyeball, the optic nerve of about 10 to 15 mm must be cut. Okay, because there will be the chances of getting some seeds of the, like some part of the retinoblastoma, chances of getting there. So if the optic nerve is not removed, then there will be chances of recurrence of the retinoblastoma, that is the orbital conditions. So enucleation will be enucleation will get the good result if the optic nerve is also removed of about 10 to 15 mm. Okay, so in the case of unilateral cases, we have to do the enucleation. If in case of bilateral cases, if asymmetric involvement, rarely exentration required. In exentration actually is a very destructive procedure. Okay, so is very destructive condition. So in better to preserve the condition of the face, or the preserve the orbital structure of the orbital cavity, better do the enucleation. So enucleation will be done only in the case of the if the intraocular, that is if the retinoblastoma is only intraocular, if there is no any distant metastasis, then we have to do the enucleation. Or in the case of unilateral, if there's a retinoblastoma is unilateral. If it involves the bilateral, then according to the asymmetric involvement, so we have to do see the which has more involvement, then that I has to be removed. Okay, rarely exentration is required. External beam radiations, that is in this, that is we have to give 40 to 50 gyra in the divided dose. Okay, the radiation should be of 40 to 50 and given in the divided doses. Uses: tumors not responding to the chemotherapy or the local treatment, tumors of the optic disc, vitreous seeding is present. So these are external beam radiations, and these are uses in the conditions like tumors not responding to the chemotherapy or the local treatment, tumors of the optic disc, okay, and the vitreous seeding. Okay, the side effects is cataract, secondary tumors, or deficient bone growth. So external beam radiation, that is a 40 to 50 gyra in the divided doses, uses is tumors not responding to the chemotherapy or the local treatment, tumors of the optic disc or vitreous seeding. Side effects includes the cataract, secondary tumors, or the deficient bone growth. Okay, then comes the episcleral plaque radiation. In this, the plaque radiations mean there is a plate which is with a radiotherapy, ionized plate is there, which is sutured over the sclera, and it is of the plate. That is the plate is made up of iodine 125 or the ruthenium 106 is used. So there is the episcleral plaque radiation. It uses radiation. It is uses in small tumors, that is 12 by 6 mm. If the retinoblastoma is solitaire, which is anterior to the retina with the minimum vitreous seeding. So these are the conditions in this which we can use episcleral plaque radiations. So this like the plaque, that is the plate is made up of the iodine 125 or the ruthenium 106, and it is used in the case of small tumors, which is of 12 by 6 mm. Or if the tumor is of solitary, anterior to the retina and with the minimum vitreous seeding. So the other is the photocoagulations. Photocoagulations means we have to destruct the retina. Okay, that is a xenon arc used, is xenon laser, xenon rays are used, and it is used in the small tumor that is of size of 2 to 3 mm thick, which is posterior to the equator, that is 7 mm in diameter, needs clear media, not to be used in the vitreous seeding. So photocoagulation is used very rarely, but in this you can use a xenon rays or the tumors in the small tumors, which is 2 to 3 mm thick, posterior to the equator, which is 7 mm to the diameter, needs clear media, not to be used in the vitreous seeding. So lasers which are used, that is, these are all the conservative management. Okay, that is other conditions in which we can salvage the eyeball. So laser, that is the transpupillary thermotherapy. That is transpupillary thermotherapy. Okay, that is the TTT. Short form is the TTT, that is transpupillary thermotherapy. It is in it, the diode lasers are used, and it is used in the small tumors that is of the 4 mm in diameter or 2 mm in thickness. Okay, so laser given around the base of the tumors and repeated after 3 to 4 weeks. That is important. That is a transpupillary thermotherapy. That has a good result. We can salvage the eyeball. Okay, so if the tumors of the size of the tumor is small, that is of 2 mm or 4 mm in diameter and 2 mm in the thickness, we can give we can use this transpupillary thermotherapy. In this, the diode lasers are used, and the laser is given around the base of the tumor. So repeated after 3 to 4 weeks. So intraocular management, that is a transfusion thermotherapy is used. This is the transfusion thermotherapy is used a modified large spot infrared laser to elevate the temperature of the tumor cells up to 60 degrees centigrade, enough to cause damage to the malignant cells. It is useful for the small center tumors in the fundus and can be used in conjunction with the endocyanin green dye in the amelanotic tumors. So this is the transpupillary thermotherapy. This is the intraretinal tumors. This is associated with the retinoblastoma, that is the intraretinal tumors. The cryotherapy can also be do. That is, cryotherapy is like increasing the freezing, that is increasing the freezing pro. That is a freeze thaw technique in the cryotherapy. So it will, because it will decrease the temperature, like of nitrogen oxide is given with the freezing point of around -30 degree centigrade. So it is used in the small to medium tumors which are interior to the equator. In this, triple freeze and thaw technique is used, repeated in 2 to 3 weeks, and contraindicated in the vitreous shading. If there is a vitreous shading, then we can't be do the cryotherapy. So cryotherapy can also be done in the small tumors, like small to medium tumors which are anterior to the equator. In this, the triple freeze thaw technique is done. Freeze thaw means we have to keep the that is a probe, that is a cryotherapy probe is there. We have to then freeze the area, and then after 1 to 2 seconds, when we get when the that is a probe get cold, or the ice is formed over the probe, then we have to remove it. That is the thaw. That is a freeze thaw technique. We have to do that 3 times. That is triple freeze thaw technique, repeated in 2 to 3 weeks, and contraindicated in the vitreous reading. See, in this, as I'm saying, this is a probe. It is a cryo probe, which is the probe, which is the end of the probe is kept over the retina. So cryotherapy is using a freezing probe to destroy the small peripheral fundus tumor. That is a small, that is destroy the small peripheral fundus tumor. Then it can be used only in, it is used only in the small tumors, small size tumors, by performing triple freeze thaw cycle technique. So this is the triple freeze thaw cycle. It is useful in unresectable peripheral retinal tumors as retinal angiomas, and is particularly very effective in the multifocal peripheral fundus tumors as in retinoblastoma. So these conditions. So this technique is used only in the small, if the tumor size is of small and it is present at the periphery of the retina. If it is unresectable, we can't remove it. So this cryotherapy is using a freezing probe. It is a freezing technique, and it will destroy the small peripheral fundus tumors. Okay. So it is particularly very effective in the multifocal peripheral fundus tumors, like in the retinoblastomas. The size of the tumor is very small and it is present at the periphery, then periphery of the retina, periphery of the fundus, then we can use this technique, cryotherapy. So these are the prognostic factors. Okay. So these are some of the conditions, or these are the factors which will give the good result, which will give the good prognosis. So first is the optic nerve. If the cut end is free of tumor, then the mortality will be only of 8%. So if the intraocular tumor does not involve the optic nerve, then the chances of, then the prognosis of the eye is good. If the cut end is involved, then the mortality is 65%. Okay. If the lamina cribrosa involved, then the chances is of 15%. Lamina cribrosa is the part at the optic disc. Choroid affected, then will be the poor prognosis. If the choroid is involved in the retinoblastoma, that is there is a extraocular extension, that is then there will be the poor prognosis. Tumor size and location also depend it also contains a prognostic factor. If there is increase in if there is a large size of tumors and it involves the anterior part, or if there is it is of exophatic type, then the prognosis is very bad. Histology, there is 3 important histology there. If there is an fluorite or fluorite of histology pattern, if fluorite pattern is there, then the prognosis is very poor. Age of onset or bilateral and heritable. These are some of the factors which have very different prognosis of the eyeball. If the optic nerve is cut end, if the cut end of the optic nerve is free of any vitreous tumors, if the free of the tumor, then the mortality is of 8%. If the cut end is involved, then the mortality is 65%. If the lamina cribrosa is involved, then there is a chance that the prognosis is of 15%. Choroid affected. If the choroid is affected, then there is a poor prognosis. Tumor size and locations. That is, if there is increase in size, or there is a according to that classification, it is of grade any. If the tumor size is of more than 10 disc diameter and it is located anterior to the retina, or it involves extraocular involvement, then the prognosis is very bad. Histology, that is the three pattern, that is the fluoride pattern or Winter-Steiner pattern. These histology depends on the they also depend its prognosis. Then the age of onset, bilateral. With the age of onset, it is if it occurs later in the after 3 years of age, of it is bilateral or hereditary. So after the treatment, so after the chemotherapy, after the laser, and after radiotherapy, the tumor will regress. So these are the after regression. That is of three types. That is, in type 1, the in type 1, the tumor will be calcific, but there will be the avascular mold. So according the retinoblastoma, that is the size of the tumor, there will be more calcific, but it will be avascular. In type 2, that is a pigmented part will get removed, that it becomes a tan, fish flash, and attenuated vessel is there. In type 3, both are there. So in this, you can see these are some of the management of the intraocular tumor. In the first photo, you can see the enucleation of the left eye. Okay, so after the enucleation, that is after removing the eyeball, that is there in this picture, there is a fitting after the enucleation, that is after the removing of the eyeball, the artificial eye is placed. So in the left eye, there is an artificial eye. Okay, in this, the right eye is enucleated, and you see the happy faces of the happy face of a child. That is, the right eye is removed, and but after that, artificial eye is placed. Okay. Follow-up is very important in the retinoblastoma case. So during treatment, that is during treatment, if that is every 2 to 4 weeks. If treatment is effective, then follow up 3 monthly for 2 years, then 6 monthly till 6 years of age, and afterward yearly check. Okay, during the treatment, during at the time of the treatment, as the treatment is ongoing, then every 2 to 4 weeks we have to then follow up must be present. And if the treatment, whatever the treatment is given, if the treatment is effective, then follow up for 3 monthly for 2 years, then 6 monthly till 6 years of age, and afterwards yearly. That is afterwards yearly checkup. So these are some of the differential diagnosis which mimics the retinoblastoma. First is the Coats disease. Okay, so Coats disease also occurs in the young age or in the children. In the same picture is that there is in Coats disease. Second is the toxocariasis, retinopathy of the prematurity, and the PHPV, persistent hyperplastic primary vitreous, coloboma of the posterior segment, organized vitreous hemorrhage, astrocytoma or medullated nerve fiber. So these are some of the conditions which mimics a retinoblastoma. So we have to go through everything very meticulously. Okay, so there is a Coats disease. In Coats disease, there is mass is present, whitish mass is seen, raised mass is seen, but there will be the more vascularization of the vessel is present. And vitreous hemorrhage and vitreous intraretinal hemorrhage is also present in the Coats disease, but it is not present in that of the retinoblastoma. Toxocariasis, it is in the toxocariasis, there is a correlateral atrophy is present in the retina. That is a round uniform oval shaped correlateral atrophy is present, which mimics like there is a mass in the retina. In the retinopathy of prematurity, as the condition is occur in the babies, in the small babies which is a weight of less than 1500, okay, and which is and they needed the oxygen supplement is given. 100% oxygen supplement is given at the time of the birth of a baby. Then in that condition, retinopathy or prematurity occurs. PSPV is a persistent hyperplastic primary vitreous. In this condition, there is a at the time that is the at the development of the vitreous, there is a that is a what it call it, that is a primitive part of the vitreous remains after the development of the after the full development of the eyeball. So there is a connection between, there is a primary hyperplastic and there is a connection between the vitreous and the eye lens. Okay, so this mimics the also mimics the retinoblastoma. That is a coloboma of the posterior segment. That is a in the coloboma of the posterior segment means there is a incomplete development of the retina of the at the posterior segment. Organized vitreous hemorrhage, astrocytoma, and medullated nerve fibers. So there also comes a management, that is a radioactive plaque, which I told you, that is a made up of iodine and the ruthenium. Okay, that is iodine 125 and the ruthenium 1 and 6. That is so what is it? It is a radioactive plaque is the treatment of choice for most medium-sized intraocular neoplasm. The radioactive isotopes currently used in manufacturing plaques are the ruthenium and the iodine 125. Dosimetry of the adequate amount of radiation to be delivered to a tumor is calculated by a sophisticated computer software. So what amount of radiation is to be given is calculated by a computer software. So this is the radioactive plaque. Okay, thank you. Okay, so thank you so much. If there's any doubt or is there anything, you can ask me a question.